So to do an RSI, we'll start by preoxygenating, just like we did for our normal. But I would almost say that preoxygenation here is much more of an important step, and we should emphasize this because you are not going to bag mask ventilate these people. If you were to bag someone during an RSI, you would insufflate the stomach potentially, break the tone of the lower esophageal sphincter, and create a direct passage for the full stomach contents to regurgitate. So you will not be bag mask ventilating. Therefore, you need to establish a good amount of oxygen in the lungs before you send someone off to sleep and ablate their breathing. Then we'll give fentanyl or some type of opioid. Maybe you'll make the case here that you should use something rapid onset like remifentanil, because technically you could decrease the level of consciousness by giving fentanyl. That's sort of a specific discussion. And again, just like for the normal RSI or the normal intubation, this will take about 5 minutes. So we want to time our intubation 5 minutes after giving our fentanyl to give it time to properly prevent the sympathetic response to laryngoscopy. So now let's time our propofol so that we're minimizing our unconscious time. So basically, we need maybe 45 seconds to a minute before we have reliable unconsciousness produced by our propofol dose. But here we're going to directly follow our propofol with sucks, 1.5 milligrams per kilogram. So instead of in our normal case where we give propofol, we wait the full minute and then we check for a response, here we give the propofol and immediately following we'll give sucks. And the timing that works out here is that by the time you're fasciculating, you will have a reasonable level of unconsciousness, but the timing here is very, very tight. And then you can intubate after you fasciculate. The entire timeline here we're looking at is about 45 seconds from unconsciousness to the tube in, and with your protected airway. So you'll insert the tube, you'll inflate the cuff to protect the airway and check for placement. Important things about the RSI are that you're using a fixed dose of your propofol and your sucks. So the sucks is 1.5 milligrams per kilogram, and the propofol dosing is whatever you deem to be appropriate for the patient. But imagine you're not checking for the response to propofol before giving your paralytic here. So you really are just making a highly educated guess of what will be the appropriate dose, and you may inadvertently over or underdose them with a fixed dose of propofol. So if you underdose someone, that poses the risk of awareness. So that's for underdosing. And then on the opposite end of that, if you give too much propofol because you want to prevent awareness, propofol has dose-dependent reduction in blood pressure, so we would risk hemodynamic instability in the case of overdosing someone. And there can be a very fine line between these. So this kind of raises this idea of these conflicts that we have, because we are choosing to do a rapid sequence induction to prevent aspiration. But at expense of potential awareness and potential hemodynamic instability. And none of these are ideal. So we have to make the choice about what one of these risks we are willing to accept and proceed with. Consider the example of a trauma patient who will be full stomach because they just had a burger, and because they're trauma, they also have delayed gastric emptying. But they also have blood loss from somewhere, so maybe an intraperitoneal bleed or a long bone fracture, and therefore they have some degree of hemodynamic instability as well. And so we are worried in this patient that they may drop their blood pressure quite substantially in response to propofol. So this is a person we are certainly worried about the hemodynamic stability of, but we need to consider the fact that they may aspirate on induction before we have a secured airway. So now let's pretend this patient also has a cardiac issue. That's going to push us to wanting to be more careful on this side of things, where we do a very, very careful induction, monitoring their blood pressure with a titrated induction. Versus if we're able to control their hemodynamic status, maybe fluid resuscitate them beforehand, and the only thing we're worried about then is the risk for aspiration, it's more appropriate to do an RSI. And I don't want to give you a concrete answer to this because each case should be considered on a case-by-case basis for the safest way to proceed. Obviously, the alternative here would be to still do an RSI using a smaller fixed dose of your medication, therefore minimizing your risk of hypotension with induction. The trade-off would be the possible risk of awareness, although this is preferable to aspiration for an emergency situation.